for inviting me to come along and talk today. I sit on the VSSC as well, and one of the problems that does come up that we see quite regularly is the problem of upper GI bleeding, either being undertreated or under-recognised, and also in our intensive care units, people having new ulcers and not having received any ulcer prophylaxis. So from that today, I'm just going to talk briefly a bit about how we can prevent upper GI ulcers and how we should respond to bleeding. So upper GI bleeding is a common problem in our community, and it's the most common gastroenterological emergency, with a mortality rate that remains at around 7% for a significant bleed. The causes are predominantly peptic ulcer disease, and just the overall community incidence of peptic ulcer is quite high, around 10%. Less commonly as a cause for massive upper GI bleeding or bleeding that would lead to needing urgent intervention, we can have tumours, AV malformations, and obviously varicose bleeding. I'm not going to focus on them today, as they're probably talks that need to be given in their own right. The risk factors for peptic ulcer disease in our community is mainly Helicobacter pylori, and that's a causal agent in up to 95% of duodenal ulcers and 70% of gastric ulcers. Non-steroidal use is also a very important etiological factor, as is smoking, and people who are undergoing physiological stress. Just focusing now then on stress ulceration, up to 15% of ICU admissions you'll see some evidence of gastric stress ulceration. It's due to an imbalance in the gastric mucosa homeostasis. As you'll be aware, in the stomach we naturally produce acid, and the stomach has quite an elegant mucosal protection system, which consists of the cell itself, but also of a relatively alkaline mucus layer that's produced by the cell to protect those cells from that very high acid load. At times of stress, you have an increase in gastrin, and that's the hormone that makes you produce more acid, but you also have people who are in ICU often have a low blood pressure, so they don't have as good a blood supply to the mucosa. And they're on medications as well that can affect that barrier or that protective mucosal layer in the stomach. So the net sum of that is that people therefore have more acid and less defence, and they're at more risk of having an ulcer. The patients at highest risk are those that are undergoing mechanical ventilation for over 48 hours, and their risk is 16 times higher than the background population. So anyone who's on mechanical ventilation really should be considered for stress ulcer prophylaxis. People also who are coagulopathic or have a low platelet count are at high stress, because that's usually an indicator of severe systemic inflammatory response, and that affects the perfusion of the stomach. People at a lower risk but still an increased risk to the background population are those who have sepsis, renal insufficiency, hepatic failure, enteral feeding, and in this I mean mainly jejunal feeding, so being fed into the jejunum rather than the stomach, because feeding someone to their stomach again helps the stomach to protect itself, whereas feeding them distally doesn't. Steroids, warfarin and heparin put people at high use. Burns, more than 35% of their body surface area. Shock, organ transplant, trauma, and if they've been in ICU for a week. And if they've had a past history of ulcers, they're obviously going to be at higher risk as well. So there is randomised controlled evidence for stress ulcer prophylaxis. Sucralfate was the first drug that was looked at. Then in a group they had a randomised 50 to sucralfate and 50 to nothing, and the risk of bleeding was 4% in the sucralfate group and 25% in the untreated group. H2 receptor antagonists, which were the next generation, so that's cimetidine and ranitidine, known commonly as Zantac, were then found to be superior to sucralfate. And then the proton pump inhibitors, which are the more modern generation of acid suppression, so Nexium, Pariet, Somac, you'll be aware of, they're equivalent to the H2 receptor antagonists, but they have less tachyphylaxis, so less allergic type reactions to them. However, there is a downside to giving people stress ulcer prophylaxis. There is an increased risk of septic complications, in particular aspiration pneumonia, but that risk seems to be the highest once they start enteral feeding. So probably the best advice from the evidence at the moment is that people who are in ICU and at high risk of an ulcer should have stress ulcer prophylaxis until they commence enteral feeding, and that enteral feeding should be gastric rather than jejunal to give the stomach its best chance of defending itself. So then moving on to what we should do when we're confronted with a patient who has a bleeding peptic ulcer. As I said before, it's the commonest reason that someone will present with upper GI bleeding in up to 60% of all episodes. The rate is thought to be 40 to 60 per 100,000 per year, and as I said before, the mortality rate remains quite high. The protocol that every hospital should have a protocol for people who present with hematemesis or melena, but the protocols in each hospital will usually go through these phases of resuscitation, an IV PPI bolus, endoscopy, and then surgery if required. Resuscitation I won't focus on too long. It's as with anyone who comes in shocked, wide bore IVs, a bolus of saline and adequate fluid resuscitation, continuous hemodynamic monitoring, and then investigations that in this situation should really include your coagulation as well as blood group and cross-match. In patients who have known liver disease, you can consider a diagnostic paracentesis, but that's more a specialty decision. There is evidence for giving PPI as soon as they present. There was a Cochrane review in 2010, and they showed a significant reduction in the proportion of patients with stigmata of recent hemorrhage at index endoscopy in patients who were given a bolus dose of a PPI at the time of presentation. However, and there was a significant reduction in the need for endoscopic intervention, so they go on to have their endoscope, you can see that it's been bleeding, but they don't actually need to have an intervention. However, there was no change in mortality, rebleeding or need for surgical intervention. So those with the most severe ulcers probably aren't going to be improved by that IV PPI, but those with less severe ulcers probably are helped. And following the procedure, there is also good evidence, again from a Cochrane review, that a continuous infusion of either a PPI or a H2 receptor antagonist will improve your rebleeding rates, and the relative risk is 0.4. So the first diagnostic and therapeutic step that we usually undertake with upper GI bleeding is to do a gastroscope, or esophagogastroduodenoscopy more correctly, and these are successful in more than 90% of the patients. I work on a busy upper GI unit at the Alfred, and we very rarely have to intervene in these patients, and Richard Cade said the same thing for St Vincent's and Box Hill. Really, the gastroenterologists now manage these very well, and endoscopy and endoscopic therapies are the mainstay of therapy. What they do at this procedure is to identify where the ulcer is, and then according to the classification of the ulcer using this Forest classification will dictate what therapies they may undertake. But if they classify the ulcer, that also gives us a chance to guesstimate what their likely recurrence rate of bleeding is. So a 1A ulcer is arterial spurting, 1B is where it's oozing, a 2A is when you can see an ulcer and you can see a vessel but you can't see it bleeding. That vessel is usually the gastroduodenal artery. In a 2B ulcer there's adherent clot, so you can't see the vessel. 2C is just a red spot, and a 3 is a clean base. And as we go down that scale, you can see the risk of recurrence bleeding goes down dramatically, as does the mortality. Oops. And that's just to give you an idea of how these things can look. This is supposed to look like active bleeding, but it just looks like a bit of a red blur. And that's how it looks when I do the gastroscopes too, a bit of a red blur, I'm afraid. So what they do is remove all the clot, stomach and ulcer, and then they get haemostasis, and that can be from injection of a sclerosant type fluid. It can be mechanical with clipping or suturing these days, and then there's the use of thermal. And mostly, particularly for those higher grade ulcers, you'll use 2 modalities to try to get good control. Now, despite initial success, if someone's still bleeding, you should never leave a patient bleeding after an endoscopy. If they're still bleeding, they probably need an urgent referral to a surgeon. But if there is initial success, at least 10 to 20% of them will rebleed, so you need to keep them in hospital and keep them closely monitored. In fit patients, up to 80% of the ulcers will be controlled at a subsequent endoscopy. So if someone does rebleed, it's not unreasonable, in fact it's probably right to do a second endoscopy most of the time. However, if the patient's unfit, or if you think there's a good chance you won't be able to control it at a second endoscopy, then surgery is really the mainstay. The predictors of rebleeding is a large size of an ulcer, so if it's a very big ulcer, if it's actively bleeding when you go in, hemodynamic instability and the need for more than 6-unit transfusion. A duodenal ulcer that's posterior will be right on the gastroduodenal artery, and so it's more likely to rebleed. And patients who have a lot of comorbid illnesses are also more likely to rebleed. The rate of operative intervention has really decreased, and that's because we are getting so much better at these endoscopic therapies, and patients who have to undergo surgery now have a very high mortality, around 25%. And that's usually because by the time the surgeons become involved, the patient's already had a significant transfusion, they're unstable, they're cold, their coagulation's not so good, and there's often been a time delay. Plus the patients are often the more frail patients that we deal with. It's also true that we now have less elective experience in dealing with ulcers, so the surgeons who are dealing with the ulcers are now, even when I was a registrar in the 90s, we saw a reasonable workload for gastric ulcer surgery. It's now really become a subspecialty operation, and so again the emergency surgeon who's on may not feel quite as confident, which certainly has an effect. So we consider, it's better to consider, if you're going to consider surgery, consider it early, and it's really important that within a hospital you have a team to deal with H&M that includes your gastroenterologists, your emergency physicians, your ICU physicians, but definitely also includes the surgeons. And surgeons should be made aware of anyone who arrives shocked on admission with an ulcer size greater than 2 centimetres. At the index gastroscopy has stigmata of recent hemorrhage and a previous admission, if they've needed a significant blood transfusion, or if they rebleed within 24 hours. All of these things should trigger an early referral to the surgeons. The surgeons may not want to do anything about it, but at least if they know about it, they can have the right team on standby to respond if they need to. It's part of working as a team, just being sure that we communicate with each other. The type of surgery I won't dwell on. Basically we oversew the ulcer most of the time. We used to do vagotomies and drainage procedures as part of this to prevent future ulceration. These days with PPIs, we don't tend to do that, as patients will be on a PPI for the rest of their life, and that's a lot less morbid than one of these operations. And at times we need to do a gastric resection. Angiography is an emerging modality that is gaining more popularity, and it definitely has a role. That role is not as well defined at the moment, but success rates are reported now in stopping bleeding of 83 to 100%. Lasting haemostasis rates again vary from 50 to 91%. In my institution we consider angiography for rebleeds after surgery, or for patients who we don't consider to be fit for laparotomy. Although I know in other institutions they will put an angiography in, an embolisation in, prior to the surgical step after a second unsuccessful endoscopy. There's no evidence either way to say who's right or wrong. A lot of it will just come down to your local resources and local expertise. So in conclusion, treatment of H. pylori has led to a decrease in community rates of peptic ulcer disease, but it's still a common problem, as is my bad spelling, sorry, I've spelled pylori wrong. Stress ulceration prophylaxis should be considered in an ICU, and it's something that we've seen several times over the last few years at the VSCC, where people have ICU patients who are going to be the most vulnerable if they do get a bleed because they're already metabolically challenged, have developed bleeding and haven't been on any sort of prophylaxis. I think there's been a real concern about this pneumonia, aspiration pneumonia, and so I guess it has to be a balance of risk. Upper GI bleeding, when it happens, definitely requires a team approach, and that team approach has to include your emergency department, gastroenterologist, endoscopy suite, surgeons, theatre suite, and critical care physicians, depending on the patient, and at times angiography, so that's usually radiology. Resuscitation is the critical step, and mostly one of the key mistakes we've seen in cases that have come through is that people have been under-resuscitated, and there's been an underestimation of how much blood is being lost. And so it's really important that patients are not just resuscitated but receive that continuous hemodynamic monitoring. PPI, there's good evidence for the use before and after endoscopy, but they shouldn't replace endoscopy. Fortunately, endoscopic therapies are usually successful, if not the first time, the second time. But if they're not successful, then they may need to go to angio or to surgery, and the timing of surgery really becomes critical to your outcome. Early referral is really critical if you want to try to get your best chance of a good outcome for your patients. Thank you.